Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today, I'm joined by Dr. David Wan, Associate Professor of Clinical Medicine at the New York Presbyterian-Weill Cornell Medical Center in the Division of Gastroenterology and Hepatology, and that is, of course, in New York City. David earned his Bachelor of Science in Neuroscience at the prestigious Brown University prior to earning his medical degree at New York University. He completed his residency in internal medicine at Presbyterian and his gastroenterology fellowship at New York University. David has a wide variety of interests within gastroenterology and hepatology, and I can't wait to dive into them. One of his main roles is in training gastroenterology fellows in endoscopy and colonoscopy and the inpatient consultation service. He's an expert in gastrointestinal haemorrhage, colorectal cancer screening, and colonoscopy, and we're going to cover all of those. He's also a member of the American College of Gastroenterology and the American and New York Societies of Gastrointestinal Endoscopy. In his free time, astonishing to think that he's got any, David's an avid reader, a runner, and supporter of the Buffalo Bills American football team, and he likes to watch critically acclaimed TV on all the streaming platforms. Don't we all? Welcome to the podcast, Dr. David Wan. It's an honor and privilege to have you here.
The privilege is mine. It's great to be here. I am excited to talk to you about GI and everything else you want to cover.
So, David, first of all, I always like to start at the very beginning. Take us on your career path, neuroscience to your current pursuits, and then I want to dig into how I think they may tie together. But tell us your story.
Yeah, so neuroscience was my concentration, what they call it at Brown, which is essentially a major. And so I already knew I wanted to be a doctor. So pre-med requirements are already a thing that I wanted to fulfill. But, I wanted to pursue something that was interesting to me. And so to me, always was fascinating was what is the biological construct of perception, of emotion, of cognition? And for me, I was like, is there some underpinning, that can help explain what we do, why we do it, our belief, our perception, and all those lenses in the way we, interpret the world. And I wanted to know is there a way to better understand that? And, neuroscience was a natural interest area for me.
Okay, well, as I say, I sort of had a sneaking connection that maybe there was something going on in your mind because your neuroscience background is interesting in that certainly since I graduated, back when there were gaslights in the street, our understanding of gut-brain interactions and functional GI disorders has changed dramatically. I mean, gut-brain interactions, back in my day, that would have meant you have an idea that you're hungry, so you go and eat, and that was about it. Talk to us about how that science has evolved during your professional lifetime.
Yeah, I fully agree. We call them diseases of the gut-brain interaction. The idea is that the gut and the brain are highly interwoven, and it's a bidirectional communication. So we know that you have your central nervous system, and we know you have your enteric nervous system. And what you perceive, what senses, pain or discomfort, and those sensations are a lot driven by internal stimuli. But how you're centrally mediated, the way you're sensitized or desensitized is really important, is really critical. Sometimes it happens early in development, that there are some critical factors, whether it's a trauma or some gastrointestinal infection that you get while your internal nervous system is developing, which can have long-lasting repercussions. And the idea that it is not foreign to anyone. People talk about butterflies in the stomach. People talk about if you're nervous, people can get the runs. You're going up on stage. People just they get GI symptoms. There's clearly a strong connection between the gut and the brain. And we're sort of, we kind of knew that, but we're becoming more, knowledgeable about things like the microbiome, things like functional MRI. There are actually, somewhat subjective and objective ways to measure these things, but clearly there are fascinating connections, which has clinical implications.
So, I mean, the things you mentioned, getting the runs, for instance, when you're nervous, there's, I'm of limited intellect, so sympathetic, fight, flight, or freeze. parasympathetic, rest, digest, and all the rest. So that's pretty clear. Our understanding is pretty clear. But you mentioned the microbiome, and I remember years ago reading about a correlation between people who have vagotomies of various heights and their incidence of Parkinson's disease, and a suggestion maybe there's a prion or something that sneaks up the vagus. What are some of the things that are happening with our comprehension of the microbiome and our cognition of symptoms and diseases?
Yeah, well, that's an area of active inquiry. So, there are everyone has their own microbiome signature. No one's microbiome is the same, and we know that the microbiome contains a rich body of genetic, information more than we even have in our own genomes, and the expression of those, the interaction between microbes, and has a big influence on development of our immune system, development of motility in the GI tract, and it's a constant interplay. And each area within the GI tract has its own microbiome, like your stomach, your small bowel has some degree of, and then your colon is where most of your most of your bacteria normally reside. And so we know that you're saying is like the connection between the microbiome and almost every disease, even mood, Parkinson's, all those things. It's unclear, how to really manipulate it, but there are associations. It's hard to say what's causality, but there definitely are differences between patients. Um, we all know that, also like simple things like just one single microbe like H. pylori, which no one never ever even heard about. And always like people always assumed ulcers are from stress, which is kind of the other thing, going back to the whole gut microbe thing. But actually, a large majority of ulcers were from this particular bacteria. And so kind of a flip side of what we were discussing. So the interaction between your gut, your immune system is so complicated and so interesting. And it comes into play in so many ways that we are just beginning to understand.
Yeah, certainly. I mean, the H. pylori work happened during my professional lifetime, and he won the Nobel Prize. He and his collaborators won the Nobel Prize for that, of course. Astonishing. So, as a surgeon and a keen endoscopist, I always enjoyed collaborating with my GI colleagues. And, in America, I know there's this. Everyone told me, "Oh, you won't be able to do endoscopy over there. It's turf wars."
Yeah.
And I was say, "Yeah, listen, what's best for the patient? Just." And I sat down with my GI colleagues when I first moved there and said, "Okay, let's work out how to work together to provide the best service for the patients we look after." I've seen diagnosis and treatment change dramatically over the course of my career. Talk us through the biggest advances that you treasure, and having gathered a number of fascinating occult cases of my own over the years, Osler Weber Rondu, for instance. Tell us a couple of, one or two really cool cases that you've seen in your career.
Yeah. So one of the things that you highlighted was that I work very much also in the inpatient setting. I take train a lot of the fellows in consultation medicine in the hospital. So it puts me in a unique position where in a tertiary academic center where I see a lot of interesting cases that, and that just wind up in a tertiary academic center. And one of the ones that I like, a case, actually, it's a first in a series of cases I've seen, and the reason why I like it because it's rare, but not rare enough because it happens, and it brings a couple clinical pearls to me. So basically, you can imagine the scenario: you have a young patient, a male or female, comes in with bloody diarrhea, lower abdominal pain, cramping, tenesmus, and they go in and you're like, oh, okay, what could this be? It sounds like there's some proctitis or some sort of inflammation in someone's lower GI tract, colon, rectal area, proctome area. So, invariably people think it's UC or something like that. It's chronic. It's not going on. It's not an infectious thing. It's been going on for months. And it ends up being like, and you scope the patient, there's some maybe non-specific thing, but there's not that much inflammation. And you're like, and you treat them like they're IBD. You give them salamines. You maybe give them steroids if you're not sure, or just because it's not working. And it doesn't work. And the patients, either get continued bleeding and they get continued pain, and I'm like, and I've seen this, and I'm not, it's just a difficult diagnosis where they come in and sometimes they can become an extremist that the pain is so severe, they're literally, you feel like they need to go to the acute, as an acute abdomen, and they need to go to the OR. And so I've had a range of these presentations, the chronic kind of smoldering colitis, proctitis, and then the acute, nearly someone who's paranetic. And so in the end, I made the diagnosis either pre and post surgery, because sometimes I did go to the OR because it was so dramatic. And what it was this really rare diagnosis on a biopsy or on the post surgical specimen called idiopathic myointimal hyperplasia of the mesenteric veins. It's a mouthful, and the reason why I like to, it makes you sound like you kind of know something.
Anything that begins with idiopathic.
Myointimal hyperplasia of the mesenteric veins. You're like, what? That's a mouthful. And so, first of all, it highlights the fact that not all the things that are IBD are IBD. You have to keep in it. What it is actually a fascinating disease that you can see pathologically, and you need to make sure your pathologists are aware of it. And you need to be, like most things, as a clinician, have it on your differential for these odd, non sort of refractory IBD cases. And it's basically where your mesenteric veins, the intimal, is so hypertrophy that it literally congests and suffocates the outflow of blood. So that it's essentially a non-occlusive ischemic injury.
What causes it?
It's
idiopathic.
But no one knows.
You must have a theory about what it is.
Some people think there's some pressurization and maybe some like fistulization between the artery and veins that leads to the compensation of the vein having to become more hypertrophic to accommodate the pressure that's there. Sometimes people see it post surgically. It's unclear, of course, but it's usually in younger males, although I've seen it in a female, and I've seen it a few times. And like, that's why I'm saying this, because it's not just these one-off things. It's happened, and I've seen it a handful of times. And I actually, one of my colleagues who is a GI hospitalist, he was like, "Hey, I've seen this too, and I saw you published a few case reports. Why don't we put this together?" And so we put together a case series, and we published it because it actually probably is more common than we realize. And that's kind of where I liked it, is like an actual case report in my personal experience led to a repeat a case. And I was like, I was like rounding with the fellows, like, wait, this has to be idiopathic myotic. And they're like, what is that? So, and then now it's kind of led to like into the literature. So there's a little bit more awareness of it. So that's why I kind of like that as my cool case that led to something.
I have to tell you, when I was an intern, a house officer in the clinic, I diagnosed a patient with porphyria, acute porphyria. And subsequently, over the course of a very long career, every time I saw a patient with undiagnosed abdominal pain, I always said to the residents, you might want to check them out for porphyria. Do you know how many other cases I've seen in all the years? Not one, not a single damn one.
You're never going to miss it, though. You're never going to miss it.
The old joke, David, is that if you see a case of something interesting, you publish a case report. And then if you do a second one, then you have a series. And then you can then write an editorial, in my experience. And then you travel the world teaching about it. Let's change subject a little bit. Colorectal cancer screening. A number of years ago, I had the pleasure of meeting Katie Couric, who, for the benefit of the British audience and elsewhere, was a very well-known American TV host who tragically lost her first husband at 42, I believe it was, from colon cancer. And Katie publicized the value of colonoscopy and had her colonoscopy on live television. They didn't actually show her naked bottom, but they showed her colonoscopy. And they, we all called it the Couric effect because a lot more people decided to have it. And she's actually a very, very sweet lady. And I really enjoyed the evening I spent with her and her husband. So colorectal cancer screening is a wonderful way to offer preventative healthcare that can make a massive, massive difference. Can you tell us your thoughts on the current guidelines? And do you believe we should be screening at younger ages? Because, of course, if someone's got polyps, maybe they've got them much younger. And can you take us through the current thinking on guaiac, FOBs, fecal occult blood, fecal immunochemical or FIT test, multi-target DNA fit, blood markers like methylated septinine, colonoscopy, virtual colonoscopy. Take us through screening. The floor is yours.
Yes, thank you, Jonathan. It's first of all, I'd say Katie was actually and her husband. They got their care here at Cornell,
Yeah.
and a lot of the efforts were done by Cornell physicians here, and so many GI physicians. And Emily Couric, who's Katie's sister, was a state senator in Virginia, and pushed a lot of legislation that put coverage for colonoscopy screening on the map. So we owe them a lot to this effort, and it's come a long way. And what we know, and what I always tell people is that colorectal cancer is probably the most preventable cancer that we have out there. Where is there a disease where we have a long latency period, we have a precursor, we know it, we can identify it in a relatively non-invasive way, and even at early stages of colon cancer, we can identify it at a relatively non-invasively, and we can take out polyps that will inevitably that could turn into cancer, and find cancer at early stages and really make a huge difference. And so they're actually so that makes me want to focus on two things. There's also there are tests that we do. They're non-invasive. It comes into two flavors. Okay, so we have non-invasive tests, and we have the more semi-invasive tests. So the non-invasive tests, you mentioned a few of them. Stool-based tests are probably the most well-established ones. Things like FOBT, which is the old school is fecal occult blood testing. We don't really do that anymore because FIT, which is fecal immunochemical testing, is more sensitive and is actually much better than FOBT because it doesn't need. It's not affected by diet. It's not affected by, you only need one test, not three separate tests, which is a little cumbersome for patients. And then there's also the other stool-based test, which is the multi-target stool DNA, which you alluded to, which basically is FIT plus looking for abnormal DNA that's shed in the stool. So it like every test, there's always a balance between sensitivity and specificity. So with the Cologuard, which is the brand name, I'll call it multi-target stool DNA, it is less sensitive and more specific. And so and it's more costly, which is the other variable. But the thing is with colonoscopy, which is, and any one of those tests, if they're positive, it kind of buys you a colonoscopy because you have a high chance of having a polyp or something more that needs to be detected and resected. And the only test that can resect a polyp, really without going to surgery, what no one would want to do, would be a colonoscopy. And so a colonoscopy, it's gone through different phases now, but because there's we have better scopes now. We have, and this we're going to talk about colonoscopy quality. There is this modern era that emphasizes colonoscopy quality. That there are certain types of metrics that we do that make sure industry standard that make sure you're getting a high quality colonoscopy. But a colonoscopy is one of the tests that can detect a polyp and resect it at the same time. And so that's one of the great things. And one of the things people don't realize about a colonoscopy, which I like to emphasize, it's the best risk stratification tool that we have out there for colorectal cancer. So what do I mean by that? So that if you have a colonoscopy at 45 or 50, in the US it's 45 because of they changed that a few years ago because of the more higher prevalence of early onset colon cancer. If you have a lot of polyps or large polyps, specifically greater than a centimeter or things that have advanced features, we know that in your future, you're more likely to develop polyps and cancer. Whereas if you have only a few little polyps or no polyps at all at the baseline, you're probably going to be, you're in a low risk category and you're going to be good for 10, if not longer, years. And so that's where colonoscopy is great for many reasons in my mind, is that you can, first of all, detect and resect in one sitting. And also you can risk stratify. But the cost is that it's more expensive. It does require the bowel prep, which is, I guess, everyone's biggest bugaboo. No one really enjoys doing a bowel prep. So which takes us to the landscape of colorectal cancer screening, and at least in the US, we still, even though it's a well-proven screening tool and it prevents colon cancer, only about 2/3 of folks actually get some form of colorectal cancer screening. So that's why, I think people are, and there are many reasons for that. Colonoscopy, it's burdensome. You have to take time off of work. You got to take a prep. People don't like the idea of doing a procedure that is semi-invasive. So they may opt for something else, or they don't opt for anything else. And so one thing that I will have to mention is that's going to maybe change the landscape is that you mentioned the methylated CEP9. So that's kind of like the old version of a blood-based test, where you think about going to your PCP or whoever, and they check a blood test, and you can screen for colorectal cancer. Wouldn't that be great? The problem is that the sensitivity of those tests were not optimal, and they weren't good enough to serve in a population-based way. But in the last year, there have been multiple advances in circulating tumor DNA, where you can now the receiver operating characteristics where the sensitivity and the specificity are at a level that the CMS or the board that dictates what Medicare will cover, it met that threshold, and now there is an FDA approved blood-based screening test that is it has its pros and cons, but is another alternative screening test for those who may not want to elect for some of the old traditional screening tests.
What about virtual colonoscopy?
So virtual colonoscopy, the good news about virtual colonoscopy is that it's non-invasive. You don't have a risk for perforation, which is one of the low, but albeit teeny risk that people are one of the reasons why people are afraid to do colonoscopies. But if you're using the more traditional virtual colonoscopies, you still need to do a prep, which is again the biggest bugaboo for most folks.
Yeah, it drove me crazy, David, because you do a virtual colonoscopy and you see a polyp. Well, you're still gonna now you're gonna have to do a colonoscopy, so it's two tests. Yeah,
So
and
yeah,
as you say, it's the prep. But I think it's one of those things. I always directed my patients. There are some great comedic turns talking about colonoscopy, and I would always give them a link to watch those things, and I would try and say, "Hey, put my hand up. I've had it. It's not that terrible, right?" I had a great line, which is. If you think the bottom's dropping out of your world, take bowel prep and feel the world drop out of your bottom. But so changing tack a little bit, fecal calprotectin. We've talked about fecal tests. How widely is it being deployed to differentiate between inflammatory and irritable bowel disease, both IBDs?
yeah, it's a great test. So fecal calprotectin is a stool test that looks for it's an inflammatory and marker of inflammation. And so, when we have someone with irritable bowel syndrome or some GI symptom where it's diarrhea or something, the question in your back of mind is this inflammatory bowel disease or not? And so actually there are guidelines through the American College of Gastro being one of them who suggest that there are certain things you need to rule out or think about ruling out before you make a more solid diagnosis of irritable bowel syndrome or some sort of other disorder. So things like get a fecal calprotectin. Rule that essentially, if it's normal, it essentially rules out IBD. You may want to get a Giardia, stool test to make sure you don't have Giardia. You may want to get celiac testing to make sure you don't have celiac, which is usually serology with tissue transglutaminase IgA, and those give you a more solid belief that the patient in front of you has more of an irritable bowel syndrome and less likely to have some of these other conditions. So yeah, it's great, and people use it now also to track people's IBD. So instead of doing colonoscopies every so often, it's almost it's a surrogate to looking at the state of inflammation in someone's colon, and you actually use that as a target now. So you can treat to target, meaning you're aiming for a fecal calprotectin below whether it's 150 or below 50. If you can get there, that means you got their colon inflammation under pretty darn good control.
I have to ask you, Idiopathic mesenteric vein. Do they get? Is their calprotectin normal?
It's normal. It's not inflammatory. It's an ischemic
Yeah.
vascular condition.
Yeah. Okay. Guessed as much,
Yeah.
but thought I'd ask. So we've talked a little bit about colonoscopy quality. I was trained in colonoscopy. I remember it well. We were told the quality metrics were successful and safe intubation to the terminal ileum, clear visualization of the mucosa throughout, completion in a reasonable time frame, and very importantly, minimal patient discomfort. And as someone who trains fellows in upper GI endoscopy and colonoscopy, what are some of the most important factors that contribute to high quality colonoscopy today? And how can we ensure better outcomes in this procedure? You mentioned perforation. I mean, in my entire career, I think I've been asked to see a handful of patients who were perforated by someone else. Um, so, yeah, floor is yours, David.
Yeah. So one thing I'll mention is that colonoscopy quality has been linked to better patient outcomes, which is important to note. There was one seminal study that looked at people who are quote unquote high performers, and they used a metric called adenoma detection rate, and they broke them into different tiers. So if you were in the highest tier, meaning you're reaching the highest rates of adenoma detection, which means that for every patient you scope, what percentage of them are you actually finding at least one adenoma or precancerous lesion? And if you're in the high detecting group versus the low detecting group, if we follow those patients out over time, the high performers had their patients had less colorectal cancer in the interval period of time that you would expect. And so the point is that one thing is that I always tell people is that colonoscopy is a very operator dependent, and like anything in life, I think surgery, everything you do, the operator plays a huge role, and there are people who are probably better than others. And the question is, how can we measure that, and how can we get everyone to meet a certain threshold? So in colonoscopy, there's this adenoma detection rate. There's things like cecal intubation rate, meaning are you getting to the cecum? Basically, it's a pretty, everyone, who does colonoscopy is pretty much hitting the cecum 95 to plus% of the time. For ADR, the threshold is about 35%. So for 100 patients you scope, you should be finding at least one adenoma 35% of the time. And so it's important. So, but what it really means is that you got to be meticulous. You got to take your craft seriously, whether it's an upper endoscopy or a colonoscopy. You got to take your time, be meticulous, because things are easily missed. Polyps, we all miss polyps. People don't realize that's kind of like, we always kind of assume patients and maybe even colleagues that once you get a colonoscopy, one person's colon is absolutely clear and you're good. But the truth is, people miss polyps. People miss big polyps, and there are consequences to that. And the best way to ward against that, is to just be as meticulous as you can and make sure you have good technique. When it comes to colonoscopy, you're looking at all the folds very carefully, withdrawing at a certain speed. And it still is a withdrawal time that's considered the standard. You have to be at least, used to be 6 minutes. They raised it a little bit recently, but basically, and I don't. The bottom line is, if you're being thorough, I think time will follow. Like, I don't think you need to time yourself and have a stopwatch in your mind, but if you're just literally taking the time, it'll naturally. You can't really do a good colonoscopy, unless unless you do it thoroughly, and then the time will follow. And then same thing goes for like upper endoscopy, which is even harder to measure quality, to be honest. But again, there are the principle is that people need to look carefully. Because I think we get a little nonchalant as gastroenterologists, I'll be honest. Like, sometimes you do an upper endoscopy and you look very quickly and you don't see any grossly abnormalities, but there are some very subtle lesions, especially things like gastric neoplasia can be extremely subtle. And so unless you're taking your time and knowing what to look for, then you could theoretically miss important things that could have clinical consequences.
Yeah. One of my teachers once pointed out that if you're doing the colonoscopy and there's an area where there's some detritus that hasn't been washed out by the bowel prep, wash it away. Because if there's detritus and there's a polyp, the detritus will settle around the polyp and cover the polyp. So that's where the little beggar is hiding. So absolutely, I'm with you. And I have to say that doing a colonoscopy, finding an adenoma, snaring it and removing it is one of the most satisfying things to do. You know, doing a major resection as a surgeon is wonderful, but sometimes it's the simple things that if you can do them elegantly and in an expedient manner, it's great for the patient. So, changing topics again, talk to us a little bit about your work delivering inpatient GI care. And I have to tell you, David, that there was a saying amongst us surgeons that as 5 p.m. rolled around on a Friday afternoon, that was when you got the dreaded referral, the bleeder who's been in hospital all week and hasn't stopped. And so please tell us nowadays about the multidisciplinary approach and how maybe a complex or interesting case that you've encountered in the hospital setting and how you approach them. We've already mentioned the mesenteric inflammatory condition, but yeah, talk to us a little bit about inpatient GI care.
Yeah, inpatient GI care has really taken off as its own discipline, I would say. And I'm part of a small cohort consortium of GI hospitalists across the country to try to kind of emphasize that there are very unique aspects of inpatient GI medicine. And as all GI hospitalists know, and we call ourselves GI hospitalists, and the most common consult is GI bleeding. Whether it's that melena you see at 5 o'clock or 12 o'clock, they call you from the ED, or it's a metachesia, or it's and the hemoglobin's like 3 and the patient's hypotensive. And those are the more dramatic cases, but you get all of this, the whole spectrum of GI bleeding. And so basically, it's thankfully, I think with the advances of endoscopy, the role for IR and surgery has diminished. I'd like to think, where and especially with what we can do now is, and this has been going on for 30 some years, but I mean certainly I think the surgeons are happy to relinquish that turf. Is that when you have someone with melena, we can do an endoscopy, and the standard is within 24 hours, and we can first risk stratify, identify the source, and treat it in one get-go. So the number one cause of upper GI bleed is peptic ulcer disease. And so we can usually find the lesion of interest and stop it with the endoscopic techniques that we have. We have so many tools at our disposal now. The more traditional ones are things like, some sort of thermal therapy. We can actually cauterize blood vessels. We can clip blood vessels. And there are actually newer tools at our disposal. We have bigger clips. We call them over the scope clips, and almost like a bear claw. It doesn't go through the working channel of the scope. It actually is mounted on the tip. So it's a much wider, it's almost like a Venus flytrap. You kind of just claw and you can get a much bigger defect. And so it's a much, and some studies seem to indicate it's actually even better than traditional approaches. And so and it's exciting. I think that's what, like you said with the polypectomy, I think sometimes as GI hospitalists, it gets I think that's something that gets us excited, and it's almost like you actually can actually see someone bleeding and treat it, and you can feel like you're actually saving someone's life, and the number needed to treat is like 2. So you're making a difference, and very few things in what we do in GI has that. You have that ability to literally change someone's pathophysiology with your hands. So that's what makes it exciting as a gastroenterologist. And some people don't like that. Some people like other aspects of GI, but certainly the GI hospitalists, they tend to gravitate to these kind of things. And so that's one interesting aspect of GI medicine that we're, and like you said, the multidisciplinary aspect. Of course, there are times when we don't get the job done, the bleeding continues, and we usually take another crack at it. We usually say we do a second look if the bleeding continues, but we usually get the IR folks and surgeons on board at that point, just in case they need to embolize or even do surgery in that rare instance.
Yeah. So like I say, seeing those patients and getting them late, it was the other one that I remember through my training as being really dramatic was the patient who bleeding from varices, and we were using Sengstack
Mm,
and Blakemore and Minnesota tubes.
yeah.
They were all the rage, and then gradually things like perivaricial injections came along and all the other techniques. Do you want to make any comment about that?
Yeah, I think and variceal bleeding are definitely scarier. They can bleed. Their patients, they're sick to begin with because they're cirrhotic,
Yeah,
and their morbidity and mortality is so high to begin with. So so you mentioned sclerotherapy, but we actually banding is pretty much the first line treatment. So you put rubber bands around these uh, varices, and they're very, it works pretty well. Even things like this is where the multidisciplinary comes in because now TIPS, which is transjugular intrahepatic portosystemic shunts, are can be employed early and or as in refractory cases. And so, if you can lower their portal pressure, that's the best way to reduce someone's variceal bleed. Of course, it's a little more morbid than an endoscopy, but sometimes it's necessary,
yeah.
and even helps prevent future recurrent bleeding. And then that's so those are but it is something. And I must say that, yeah, if that doesn't work, then I think it becomes really tricky. Where that's where if the bleeding gets out of control, that's where that's the ones that we're really trying. I've had to put a few Blakemores in, and just as a temporizing thing to get them to tips.
Yeah.
Um, and those are the patients that are, those are the most dramatic cases that we see.
So you've told us about advances in circulating DNA testing for colon cancer and some of the things that have happened with the toolkit. The scopes are certainly. I remember learning. I mean, when I learned, David, it was with a teaching attachment, right at the side, and then actually that's how I learned to do laparoscopy as well. So every time someone moved the laparoscope, you get a black eye. So the quality of the equipment has changed dramatically. I know that, and the training and the visualization, the quality of the visualization. What is at or just over the horizon in gastroenterology that most excites Dr. David Wan?
I think it has to be AI, artificial intelligence. Everybody talks about AI in every single industry, and GI is no different. We actually, we talked about colonoscopy quality and polyp detection. Well, it's been around for a few years now. And I've done some work with this where you can turn on a module, a machine, and it will actually help highlight polyps that you may not appreciate early on. Put a rectangle around it on your screen in real time and say, hey, look at that. That may be a polyp. And so that's something that's already available. And but AI has so many more potential applications in anything, in terms of, will AI make life easier? It can maybe even help tell us what kind of polyps are the ones that should be taken out or not. Like it can help characterize polyps. Maybe it can help, grade the prep score and then generate a note without even having the GI doctor have to say it to do any dictation or whatever. It'd be all quote unquote automated. Um, and those are the kind of things that, we're looking at. And so we're just kind of scratching the surface of what AI can do. And this is also for other aspects of not just medicine, which is one of the things I think I'm excited about. Like for me, one of the things of course, people like to do what they like to do. They don't, and I mean, at least in America, we have a lot of time writing notes and documenting, and and it is very cumbersome. And so, the idea, if we can have ways that AI can help dictate, help save the time, so we don't have to worry about all that, which many of us take home after hours or writing notes, and it certainly has an effect on people's quality of life. And so those are the kind of things that I think AI could have a role in. And so that's some of the things I'm excited about um, within GI.
Yeah, I think you're right. But I think it's also apparent that all of these technologies need a human being. Um, I fly airplanes for avocation, and we have a lot of technology in the cockpit of an aircraft. But there's the old joke about the passengers who are in the rear of an aircraft, and the pilot's voice comes over the tannoy as they're taxiing. It says, "Ladies and gentlemen, welcome to the first completely humanless piloted AI aircraft. We want to assure you that nothing can go wrong. can go wrong, can go wrong, can go. So we need to have human oversight. David, I always like to finish with a question for all our guests. If a magic genie could grant you 3 wishes in your area of healthcare, what would you wish for?
Yeah, that's a great question. Well, one thing I sort of alluded to is that how can we make less busy work and less, you know, kind of right, you know, all those things that kind of eat into our time in our day. And so, for instance, you know, when we're seeing patients, you know, I'd rather be looking at the patient, talking to the patient, and not having to be worrying about charting and writing notes. And so, if there are ways to improve that, and so we can do more of the things that we want to do, like face-to-face time with patients, I think that is what, in some way, whether it's AI or whatever, you know, whatever can help improve that system. Other things here, and things like things I think of in America are, it's bigger questions, right? Like there's so many healthcare disparities in medicine, socioeconomic determinants of all those determinants of health really dictate a lot of what what care a patient can have. And so, and truthfully, it's a more societal problem. I don't know. There's no easy answers to those questions, but if whatever we can do to try to minimizing those gaps in care, so that no matter where you are, if you're an urban or suburban or rural setting, uh, whatever racial or socioeconomic status you come from, that you should hopefully be able to get access to care, and because that's not honestly the case, and for many people. And sometimes we also make decisions too, based on insurance carriers and what they pay for. So, like for instance, in IBD, there's so many new developments in terms of the biologics and therapies, and sometimes, we're kind of our hands are tied behind our back because we have to try some of the older drugs that we know are not as good as some of the newer drugs, but because of insurance coverage, there's always this song and dance that one has to play, to get the medications that we know or we think will give our patients the best possible care. And so a lot of our time and efforts and it has to be placed into navigating that complicated landscape. So I'm not again in my dream, my vision. I think if we can figure out better ways of kind of minimizing that red tape, kind of make things, obviously things can't, there has to be some guardrails, but I think, making things that are widely accepted in the clinical sphere that are considered best practices shouldn't have to be so hard to implement.
Yeah, if you make the mistake of applying rationality to this conversation, you will go slowly mad. One of my pleas has been, having practiced on both sides of the Atlantic and spent literally half my life in America. There are many wonderful things about American medicine, and there are many things that make me scream. Same over here. There are some things about British medicine that are really, really good, and there are some things that are bloody awful. And I just wish a group of us doctors who care could sit in a room and say, "Hey, you guys do this really well. Um, why don't we implement that?" And wouldn't it be wonderful if doctors actually ran the healthcare system instead of people with MBAs? I'm afraid that's all we've got time for today. I'd like to thank Dr. David Wan for being with us today and for everything you have done and will do for patients. Thank you so much. It was a real pleasure chatting with you.
The pleasure is mine, Jonathan. I appreciate the time. And David,
Fantastic.
thank you so
Well, we
much.
must do it again, because at the speed things are changing, I'm sure you'll have more to tell us. So, to the folks listening, if you've enjoyed this episode, please subscribe on Spotify or Apple Podcasts so you never miss an episode, or frankly, wherever you get your podcasts. Leave a review, tell your friends, you know the drill, and check out the archives. There are several hundred wonderful conversations. I've been very privileged to meet with some amazing people. And join us next week for another fascinating episode. Until then, I'm Dr. Jonathan Sackier. I thank you for listening to the EMJ podcast. Please, everyone, stay safe, stay well, and stay curious. Bye for now.